Then we'll move into discussing the risk factors, and for that, the different types of workplace violence and the types of workplaces and professional groups who are at increased risk. Third, we'll talk about the consequences. What consequences does violence have for the individual employee, for their health, their safety, but also what are the consequences for the quality of the patient care that you're able to provide. And then finally, we will talk about management and prevention. My focus as a researcher, I've been studying this topic for many years. My main point is that this is an organizational issue. This is not an individual issue. But that being said, there are individual strategies, and I'm hoping that you can learn a little bit about that as well as organizational strategies today. So, how do we define workplace violence? Well, I give you two definitions here. The first is about 20 years old and comes from OSHA, the Occupational Safety and Health Administration. And their original definition was any physical assault, threatening behavior, or verbal abuse occurring in the work setting. And that was the definition that guided much of the research for the last couple of decades. But in the beginning of last year, the Joint Commission, who I'm assuming you're all familiar with, Joint Commission is the organization that is the accreditation body for the majority of US hospitals. As you can see, their definition is much, much broader. This came out in their workplace violence prevention standards about a year ago. And violence is defined as any of the following: verbal, nonverbal, written, physical aggression. It can be intimidation, it can be harassment, it can be sexual harassment. Physical assault is included here, or other behaviors of concern involving staff, practitioners, patients, or visitors. So what's the purpose of such a broad definition? Well, the Joint Commission wants to set a precedent that any type of dangerous or harmful behavior, and it can be harmful to practitioners, it can be harmful to patients or patient visitors, should simply not be tolerated. So how big is the problem? I show you here data from 2011 to 2018. This is data from the Bureau of Labor Statistics that was compiled in 2020. In the chart on the left, chart number 1, these are incident rates of violent events to healthcare workers. So these are rates per 10,000 full-time workers. And what I want you to see here is that the rate was somewhat over 6. So 6 incidents per 10,000 workers in 2011. By 2018, the number was well over 10. So a steady increase in violent events. In chart number 2 on the right, you have absolute numbers. So the same time period, but these are numbers of violence-related injuries or illnesses with days away from work. And this is for all industries combined. Again, a steady increase from 2011 to 2018. But here, what's important for you to see is that the red part of each bar represents violence-related injuries in the healthcare industry. So about 3/4 of all violence-related injuries are occurring among healthcare workers. So here's a little bit of a summary. These are the incidence rates of non-fatal intentional injury by another person in selected industries. For all industries combined, the rate was about 2.1 per 10,000 workers. In healthcare, it was 5 times greater, about 10.4. If we look just at hospitals, the rate's even higher, about 12.8. and it's 60 times greater if you work in psychiatric or substance abuse facilities. So, key points for you to remember. Healthcare workers in the private sector are about 5 times more likely to incur violence-related injuries when compared to workers in all other private industries. About 3/4 of all of the violence-related injuries and illnesses that are reported are incurred by healthcare workers. The rates of injuries have increased steadily since 2011, and the rates are clearly highest for anyone working in psychiatric or substance abuse facilities. That was data that included 2018. There is new data just recently out, which unfortunately does not show a decrease. And we have at least anecdotal evidence that violence increased during the pandemic years. I give you two publications here that may be of interest. The first was in JAMA, and it was mostly anecdotal reports. And there was a recent study by a nurse researcher who showed in a small study of about 200 nurses that those who cared for patients with COVID-19 experienced more violence compared to nurses who did not. But there's a caveat with all of these statistics, especially the official statistics that we get from the Bureau of Labor Statistics. And that is that the events that are reported and the injuries that are reported are only those that result in at least 1 day off of work. And what our research has shown is that there is a tremendous black hole of data that we're not collecting. So why is workplace violence so tremendously underreported? This is something that I have studied for many years. It's not simple, but I give you here some of the main reasons that healthcare workers don't report incidents of violence. First on the list is that many, unfortunately, consider this simply part of the job. So that in some settings, especially, I will say, psychiatric facilities or emergency departments, there are simply high thresholds for violence. The other thing is that if an individual doesn't incur a physical injury, they don't see the point in reporting. Many times we hear, well, the patient didn't intend to hurt me. The patient can't be held responsible for their behavior. This can be a patient who has dementia or some other form of cognitive impairment, or someone who's under the influence of drugs or alcohol. Another reason for not reporting is that it takes time, and healthcare workers are often extremely busy just under normal circumstances. Unfortunately, we also see that many people can take this upon themselves. Well, the patient reached out and assaulted me. I must have said something wrong or done something wrong. Feelings of guilt or shame or responsibility can also hinder reporting. You can also have a workplace culture that doesn't support reporting of violent events. So what we hear is, well, no one got hurt and everything's okay, so why bother to report this? It just makes us look bad. And last on this list, but not at all the least important, is this notion of, well, nothing ever happened, so why should I bother to report? So it's a complicated issue. And we have, in the research world, tried to quantify underreporting. Here are results from 2 different studies with very similar results. We looked at self-reports of documented incidents and compared self-report on a questionnaire compared to documented incidents in 7 hospitals and found an 88% rate of underreporting. We even found that an informal reporting to a supervisor, just verbally, was underreported by 55%. And colleagues of mine in Texas did a similar study, and they found an 81% underreporting. So what does that tell us? Well, it tells us that we really only know a fraction of what is going on. And underreporting is a big hindrance. It's a big barrier to violence prevention for 2 reasons. First, and obviously, it's giving us an underestimation of the true extent of the problem. And it may be indicating less of a need for prevention than may actually be the case. But I think most importantly, it's giving us an incomplete picture of the full spectrum of violent events that occur. So we may be establishing prevention efforts that are only addressing a limited piece of the problem. And I have a picture there to show you that violence can be bullying and harassment or aggression. It doesn't have to be a violent act that results in a physical assault or injury. So we're going to move on now to look at what some of the risk factors are. And before we get into that, I think it's important, some of you may be familiar with this, but in this field, we categorize workplace violence based on who the perpetrator is. And there are 4 types. Type 1 is criminal intent, where the perpetrator has no formal association with the workplace. This is usually a crime being committed, and an example would be a holdup at a convenience store. Type 2 is customer or client, and the perpetrator would be, in this case, in healthcare, a patient or a customer, a visitor of a workplace. This is the most common type of workplace violence in healthcare. But type 3 is worker-to-worker violence, where the perpetrator is a current or a former employee of the workplace. You may all have heard about a faculty member who was shot and killed yesterday at the University of North Carolina. A tragic event which would be classified actually as a type 3 event, where it was a student who was the perpetrator or is the suspected perpetrator. The 4th type of workplace violence is what we call personal relationship, where the perpetrator is not formally have any relationship with the workplace, but does have a relationship with an employee. And this is often a spillover of domestic violence. So those are the 4 types of workplace violence. And actually, all 4 types do occur in healthcare settings, but as I mentioned, types 2 and 3 are the most prevalent. And this is kind of a generalization, but violence from patients and patient visitors tends to be more physical, can range from scratching or pulling hair to biting to actual physical assault, whereas type 3 is more often non-physical violence. But this too, it's a broad spectrum and can range from verbal abuse to systematic bullying. When we talk about risk factors in hospital settings, we know that there are certain hospital units that are at increased risk. As I've already mentioned, psychiatric or mental health facilities, certainly emergency departments, geriatric or dementia care units, and intensive care units are all at increased risk. But there are also non-hospital environments where violence is a risk. Ambulance or EMS workers, nursing homes, outpatient mental health facilities, and home health care. And this is actually a growing area of research. You're, of course, most often working alone, and you're in another person's home, which is an uncontrolled environment. You can also be working in a neighborhood that has a high crime rate where the risk of violence is increased for that reason. When we look at professional groups who are at greatest risk, the numbers that you see here are based on a study that my team did about 10 years ago now. And this was based on a hospital system, multi-hospital system with about 15,000 employees. We found that mental health technicians had the greatest increased risk, followed by security personnel, followed by nursing staff. But what we also found is that we know very little about violence against physicians. And why is that? Well, in the same study from 2011, we found that the physicians were not often, mostly they were not employed by the hospitals, but they were employed by their physician groups. And because of this, they were not included in the human resource database, which was where we got our information on where they worked, on their hours and so forth. So there have been some studies of specific groups. I give you here one study that we did, a national study of violence in obstetrics and gynecology. But more than this, we really don't know on a national level. A study by colleagues of mine, again in Texas, did a systematic review of workplace violence in outpatient physician clinics. This paper came out in 2020. They reviewed 18 papers, and lo and behold, none of them were from the United States. So this is again an area that we need to learn more about. A recent research letter in JAMA Internal Medicine did show that physicians were the object of personal attacks and sexual harassment on social media. But this was a relatively small study, the relatively low response rate, but we did see that about a quarter were personally attacked, and that the attacks related to such things as social, political issues such as guns, vaccines, abortion. The people also reported being attacked because of their race, their religion, or specifically because of patient care that they had provided. And about 10% reported online sexual harassment. So more to learn there about violence against physicians in particular. When it comes to understanding risk factors specifically for patient-to-worker violence, there is a great deal of research on this. And here I refer you to a quantitative study that was a literature review as well, and a qualitative study that my own team has conducted, where we examined documented incidence reports to see what, if we could glean from those, what some of the risk factors for violence were. And what's interesting is that even though one study was quantitative and the other was qualitative, our results were very similar. So main risk factors, and some of these I've already mentioned, are patients with an altered mental status or patients who have behavioral issues. There can be intoxication, delirium, which is rather common on intensive care units, psychosis, any kind of cognitive impairment. But we also found that patients or patient visitors who are angry, upset, very worried, or dissatisfied with care, and this can also be patient visitors or parents of pediatric patients, This increases the risk of violence. Being in pain or under medication withdrawal is another risk factor, and anyone with a history of violent behavior, which unfortunately in some clinical settings is not always known. In our qualitative study, we looked at, we categorized the incident reports according to three main themes. The first was patient behavior, and in addition to cognitive impairment, we also found that patients who were demanding to leave, especially an inpatient setting. But we also found that during patient care, there are certain risk factors, and one of the main ones to come out in this study was needles. As soon as a needle is presented, it's important to be aware that patients can behave violently, even patients who show no form of agitation or anger. Being in pain or discomfort increases the risk, and during patient transfers. And the third category was what we called situational events. So any transitions in care, being admitted, being discharged, and patients coming into primarily a hospital in police custody. We also know that there are certain environmental risk factors. Poor environmental design, for example, where there's no means of escaping if a violent event is underway. You can have blocked vision because of poor workplace design, or it can be a very open workplace with a lack of protective barriers. There may be a lack of security alarms or panic buttons. Poor lighting indoors and outdoors is another environmental risk factor. And a lack of metal detectors. I have a question mark on that one because the research is actually very mixed on whether metal detectors are effective. And some situational risk factors, which I think we've already mentioned: long waiting times, any kind of misunderstanding, if the patient is feeling that their needs are not met or they're frustrated, short staffing, and working alone. And we, as I said, in my team, our focus has been very much on organizational factors that influence workplace violence. And what we have found is that there are work environment factors that play a very important role. Work stress, if your clinic or your work unit is under great stress, the risk for workplace violence is greatly increased. On the other hand, if you have a strong safety climate at the workplace, specifically what we call the violence prevention climate, where staff feel that supervisors have their back and support and do what they can to mitigate violence, there is actually less violence reported. And then that middle box looks at staff interaction. And what we have found is that if there's a lot of conflict between employees, the risk for workplace violence is increased. On the other hand, if you have an efficient workplace where things flow well and there's good teamwork, the risk of violence is diminished. So important to keep in mind. We're going to move on now to the third section and talk about some of the consequences of workplace violence. Here I refer you to an excellent paper by colleagues in Canada. They looked at, they did a systematic review of the consequences of workplace violence. And what they show very clearly is that, quite obviously, there are consequences for the individual employee. You can be physically injured, but there are also psychological effects. What we have found in our research is that some of the main reactions to a serious violent event are fear and anger, and they usually occur in that order. But under sustained violence, we see increased depression and anxiety. In severe cases, even post-traumatic stress. And there are a great many studies linking workplace violence experience with increased burnout. Not surprisingly, there are consequences for how you perform as a healthcare provider. You can have decreased work satisfaction, your motivation is decreased, and there can be a decreased ability to concentrate, to focus on your work. I'm going to come back to that in a minute. Many studies also show that there is increased absenteeism or presenteeism, which means that you're at work, but you're not really giving work your all. And obviously, workplace violence can have serious implications for an organization, not just because of increased absence or turnover, but there's an increase in costs. What does it cost to recruit new providers? Their medical, legal expenses, and workplace violence, if it becomes known, can actually have a serious impact for an organization's reputation. What has interested me from the very beginning, as I said, I've been studying this for many years, was the impact of violence on the quality of patient care. This is a study from way back, 2001. And what we did was we studied a large hospital system, and we found that hospital units with higher rates of staff-reported violence had lower ratings from patients of the quality of care. More recently, we looked at nurse-reported bullying, and on a unit level, we found that bullying amongst nurses was significantly associated with the incidence of central line associated bloodstream infections, or CLABSI. And again, this was on a unit level, but the link was very clear. We mentioned, again, what the mechanism could be. I mentioned earlier that violence can have an impact on your ability to focus at work. I have become, in the last few years, very interested in cognitive failure, measuring cognitive failure at work. We have some preliminary data that indicates that this could well be the case. And it's not so surprising. You can have difficulty concentrating. You can become more forgetful or distracted. And this can affect the way you communicate with your colleagues. And of course, it can affect the way you communicate with your patients. So I could talk much, much more about this, but we do need to move on to the fourth section of this talk, where we're going to look at management and prevention strategies. So the Occupational Safety and Health Administration, OSHA, came out with these guidelines for preventing workplace violence in healthcare in 2004. They have since been updated several times, most recently in 2016. But if you have not seen them, there is a lot of very good common sense suggestions and information in here. They suggest three general approaches for preventing violence. They are environmental, organizational, and behavioral. And I'll just review each of those very briefly. So an environmental strategy would be any measures that would create a safer and more positive physical work environment. These are usually engineering controls. So it can be controlling of entries and exits, for example, with metal detectors, increasing the lighting, installing alarm systems, any type of physical separation or barriers with between workers and customers, cashless transactions. An administrative strategy would be any type of program, policy, or work practice that's aimed at maintaining a safe environment. I give you a few examples here. The first, flagging charts, I have highlighted because the research on flagging charts and the efficacy is very mixed. And I give you a few references there. If anyone is interested, I would be happy to provide them. I will say that our colleagues in Canada don't believe in flagging charts, and they see it as a breach of patient integrity. A zero tolerance policy is another example. And in my view, the most important that any healthcare organization or unit can do is to continuously assess risk situations by incident reports. And then there are behavioral strategies, which often are training. So in training employees to better manage or to cope with violence if and when it does occur. And there are a few examples here would be conflict resolution training, stress management, debriefing, which would be post-incident. Any type of educational program would go under this category. As I have said, organizational strategies is that's where my heart is and where I believe the most important prevention occurs. And I'll briefly review 3 types of organizational strategies: unit-based interventions. We're trying to predict violent patient behavior before it occurs, and there are also specialized response teams. Unit-based violence prevention is what we explored in a major grant from the CDC NIOSH. For this study, I partnered with the Detroit Medical Center, and really our aim was with this project was to develop standardized methodology for violence surveillance, risk assessment, and prevention. I could speak at length about this, but I will just review very, very briefly what we did. So there were 7 hospitals that we were comprised of about 1,100 individual units. We identified 41 units which were at high risk for workplace violence, and we randomized them to an intervention and a control group. The intervention that the 21 intervention units received was what we called a walkthrough. Each supervisor from each unit was presented with a summary report of their workplace violence data for the past 3 years. The data were compared to corresponding data for the entire hospital system. And based on the data, each unit was instructed to work with their teams to develop an action plan for prevention. So this is really what it looked like. We identified the high-risk units. The walkthrough was limited to 45 minutes. We never exceeded that. The idea was to make this as clinically feasible as possible and not interrupt the operations of the clinic or the unit. The supervisor was then given their data, reviewed the data, and they were given a modified checklist, which comes from the OSHA guidelines for intervention strategies. And based on that, they were to work with their staff and develop an action plan. This is just a piece of the OSHA checklist that we adapted for hospitals. If anyone is interested, this is available at the Joint Commission website, and also we have published on this checklist. And what did the intervention show? Well, it was very positive. So 6 months post-intervention, we saw significantly lower rates of violence on the intervention units compared to controls. And 24 months post-intervention, we saw significantly lower rates of violence-related injury on the intervention units compared to controls. So this was for us very exciting, and we've published 2 papers on both the actual intervention results, but also on the process describing the walkthrough intervention. I also mentioned that there are tools that try to assess the risk or predict patient violence in healthcare settings. I list only 3 here. There are many. Some of you may be utilizing other tools that I haven't listed here. But I do cite a review article that looks at the validity and utility of some of these instruments. And here again, the results are mixed. This is a relatively new idea, the idea of specialized response teams. And this is something that we're seeing more and more of. BERT teams, or behavioral emergency response teams. These are staff members, usually nurses and social workers from behavioral health services, who have experience in caring for patients with psychiatric disorders or assaultive behavior. And units can call on these BERT teams to help them with patients whose behavior becomes difficult. There are also, it's similar, but they're called med-psych teams, and these are usually more skilled staff who are integrated into units who don't have experience in working with assaultive patients. So if we're going to just sum up briefly about the organizational approaches, these are the critical elements that I would like you to be aware of. Both management and employees have to play an active role in enforcing policies and in establishing a culture of safety, what we call psychological safety. So there can't be any retaliation or reprisal for reporting. Both management and employees also play a role in monitoring what happens, in holding individual work sites accountable, and in seeing to that education and training of employees occurs. And that brings me to the final piece, where I'd like to review a little bit about what you as an individual can do to prevent violence and to prevent harm. I've said before, I see workplace violence very much as an organizational issue, but violence does occur, and there are things that the individual can do to at least try and mitigate patient violence. And I think that there are certain basic skills that everyone can learn to maximize their safety. We conducted a qualitative study where we interviewed victims of workplace violent events very shortly after the incident occurred. And we also interviewed what we called skilled workers that the units themselves identified as folks who were very good with aggressive or assaultive patients. And it was very interesting to see the differences between these 2 groups. So the incident victims showed much less tolerance towards the patients whose behavior they very often attributed to mental illness. They exhibited a greater sense of urgency to stop the aggression, and they were also much more likely to identify challenges to dealing with violence. Whereas the skilled workers were very different. They expressed empathy for the patients. They didn't take the patient's behavior personally, and they made a point of saying that. They had strategies to establish rapport with patients who were agitated or aggressive, and they were very good at giving patients time and space. And what we found was that what the skilled workers were expressing and describing to us was basically de-escalation. So de-escalation is a combination of strategies or methods that are intended to reduce a patient's agitation and aggression. And it really has its foundation in establishing rapport to gain the patient's trust. It focuses on minimizing restriction to try to protect the patient's self-esteem, and just intuitively trying to be creative and flexible in finding ways to reduce the patient's need for aggression. This sounds easy, and it's not. But I think it's important for you to be aware of what some of these elements are. And this is a table from an excellent paper that reviews de-escalation, if anyone would like to read more. So the 5 main elements are communication, which is how you communicate with the patient, but also self-regulation, which has to do with how you maintain your own behavior. Assessment is assessing the situation, not just the patient's state, but also what's going on around you. What are the risks of whatever interventions you might consider, and judging the trajectory of the situation. Actions, that's what activities you would do to help displace or help try to mitigate the patient's anger or frustration or whatever is at the root of his or her violent behavior. One of the skilled workers who we interviewed had an amazing way of just saying to the patient, walk with me. Let's leave this room. Walk with me. Talk to me. Tell me what's going on. And it worked very, very well every time. So that would be a way of decreasing the environmental stimuli, taking the patient out of the situation. It also is important to be on the same level of the patient. Sit if the patient is sitting, stand if the patient is standing, so that you're on an equal footing. And then, of course, maintaining safety. You have to be aware of the patient's movements, aware of what's going on around, and making sure that you are allowing the patient personal space. I think what's very important with all of this is actually a commentary piece from the Nursing Standard, where a nurse wrote, difficult patients can be hard to like, which can in turn affect the care they receive. But make the effort to step into their world and you can transform the relationship. And I think this is what is at the heart of de-escalation. And again, this is not easy, and busy and maybe stressed healthcare providers can find this very difficult to do. But I think it's important to try and maintain that empathy and try and see the situation from the patient's perspective. So some of the take-home points before I close. Patient violent behavior, we definitely know, is more prevalent in certain environments, and there are certain risk factors in certain types or groups of patients. But I need to underscore that nevertheless, some behavior is not predictable. I have focused on the organization and what the organization can and should do, but the individual healthcare worker response also can be influential in mitigating patient aggression or potential violence. And some of the key elements of de-escalation are empathy, self-regulation, so regulating your own thoughts and behavior, taking time to assess the situation, trying to slow things down, of course, maintaining your own calm if you can, and being aware of your surroundings so that you can maintain safety for those around you as well. So workplace violence is difficult to address. I think you've understood that one of the main causes is underreporting. It's a major barrier to giving us accurate prevalence and incidence data. Violence is also perpetrated by different people. There are different types of violent events, everything from verbal abuse to shootings. And of course, risk factors differ in different care settings and with different kinds of patients. So as I said, it can also be unpredictable. And unfortunately, we don't believe that a one-size-fits-all approach may be feasible because of all of these different factors. The main challenge is, I leave you with this question: how do we change the mindset of healthcare managers and employees from violence is part of the job to violence is a problem that needs to be better managed and prevented? And with that, I thank you so much for your time and attention, and I would be happy to take any questions if there are any.
Thank you, Dr. Arnetz. That was great. The chat box is open for questions. One question that has come up is the slides, and we will be able to make those slides available. I believe we'll have them posted on our HFPN website, but Lily can provide more details in the chat box. Let me just start with a question while others are typing other questions in. And this question is kind of a broad question, and it may be slightly out of scope, but we've certainly seen an increase in mass gun violence across the nation, and this seems to be occurring almost in parallel with the violence increase in workplace violence. Do you think there are some common societal factors that may be driving both of these trends?
It's a really great question. I can't say that I have data to support it, but my instinct is that the answer to that question would be yes. Our society as a whole has become much more violent, and I think that during the pandemic, through the interviews that we did and the surveys that we did primarily with nurses, we sensed that there was a lack of inhibition from patients and from their loved ones. It was kind of, you're here for me, you're here to be helping me. If I'm not getting the service that I need, I'm lashing out. And it might not have always been physical violence, but a great deal of, we see this increase in irritability and just aggression. Does it go hand in hand with the increase in guns that we have in our society? Hard to say. There are still incidents of guns getting inside of healthcare organizations. Very often it is a disgruntled patient or a patient relative who wants to take revenge in cases like that. Thankfully, those incidents still remain in a minority of everything else that occurs.
Thank you. There is a question from Kelly, who is asking how you specifically defined the high-risk units in the study that you did at DMC.
Yeah, great question. So those units were defined, that project was completely data-driven. So we based it on on the rates of violence on all of the 1,100 units across the 7 hospitals, and units that were at clearly increased risk. I don't have the numbers in my head. Those were the units that were identified, and we've published on this. If anyone is interested, I would be happy to share that. But it was based on reported violence.
And I think from your earlier slide, those would be either psychiatric or behavioral health units, intensive care units, emergency room types of units. Would that be true?
That is correct. Although we did have in our study regular med-surg units as well, step-down units. Wherever the rates were highest, they were included in the study, and they were randomized to either intervention or control. But of course, we did have all of the emergency departments were included in our study, as were mental health facilities. Yeah.
Question from Richard relating to the fact that our Canadian colleagues don't seem to support flagging in the chart as a way to identify high-risk patients. Can you kind of describe that situation and maybe what their objections are?
Much of the research on flagging comes out of Canada, so they have been intent on trying to make this part of their process. But what their studies did not show a decrease in violence based on flagging charts, and they question whether it's a fair thing to do, because by highlighting a patient's chart, you may be making employees on their guard and more ready for a violent event to occur. I think that's about the best that I can say. I do know that many healthcare systems in the U.S. are practicing flagging to some extent.
Thank you. The next question is from Maureen, who asks whether you predict that laws or regulations will be changing within healthcare. And I think they're referring to not only healthcare regulations and healthcare rules, but also social laws and rules. Do you expect that there will be changes coming in the near future given this adverse trend? And what are your thoughts on that?
Yeah. I could talk for at least an hour about about this and about the need for legislation. I can say that in my office right here, I'm right next to a large hospital, and when I walk in there in the morning to buy coffee, there's a big sign on the glass saying basically that violent behavior is not tolerated anywhere in this building. This I find very encouraging. But you should know that there has been legislation that has been introduced. It hasn't gone anywhere. It started in 2017. It was passed by the House and was stalled in the Senate. There's now new legislation, which is called the SAVE Act, which, I'm trying to see if I can find the name of it for you. It stands for Safety from Violence for Healthcare Employees Act. This too is stalled. I'm hoping that it will get out of committee and perhaps come up for a vote. There have been attempts made, but something I've been fighting for many years. We need to see more of it. I would like to see, I thank you for your question, because I think the need for that culture change, both within organizations, but also on a federal level, as well as on state levels, is necessary.
Sounds like we could have another webinar on that topic alone. I do want to throw one really quick question in for you. This is from Jane, and she asks, Henry Ford Health has taken the step to arm many of its security officers. This is a big step for us. Is there any research to support the arming of security officers within healthcare to reduce the risk of violence?
It's a great question. I do not know of any research about this, but I will say from our intervention study, one of the action plans that came up from one of the units was to arm their security guards. The security guards did not want to use the arms, but their feeling was that being armed was a detriment to violent behavior. And they saw it as being basically a safety mechanism.
Right.
So it's anecdotal. I don't have any, I can't refer to any research, but we did see the violence decrease on that unit as a result of that intervention.
Well, I think we've come to the end of our time. First of all, I want to thank you, Dr. Arnetz, for your insightful presentation today. I think we are encouraged to know that your work is gaining momentum and that healthcare organizations are starting to understand the problem and look for ways to make our workplace safer. We also look forward to learning more from you in the future, and it sounds like we have a good topic for our next webinar with you. But really, on behalf of all healthcare workers and certainly everybody on this webinar, we want to thank you for all of your efforts to keep us safe and to protect us. Thank you. And
Thank
before
you.
we sign off, I just wanted to call your attention to the slide that's showing. This is a shameful plug for our, I should say shameless plug for our HFPN 2023 Summit. It's happening on November 9th at the MSU Education Center in Troy. We'll have a reception from 5:30 to 6:30, followed by the event from 6:30 to 8. The topic is artificial intelligence. What's it got to do with you? And we have our keynote speaker, Dr. David Allard, who is the CMIO for Henry Ford Health. We also have some very exciting panelists that will be talking about AI and what we can expect from AI in healthcare in the coming years. So again, thank you all for spending your lunch with us today. We look forward to seeing you at the next webinar. Take care and have a great day.